for extraction, because that's the only thing that was going on. So that's when fortunately I got taken up by the hospital, and I was the only periodontist working that time, like a hygienist, cleaning all the plaque and calculus. But I think that journey has been really nice, and since then I've been seeing so many elderly patients that I really feel that there is a lot of paucity of knowledge when it comes to fellow dentists as well as other specialists. So I think that this session is a must, and that's why I was stressing on the fact that they should go online, so that at least the share can be seen, the link can be shared and can be viewed by many other dentists all over India.
Hi,
That's
ma'am.
great, Ishita.
Yeah.
Hi, ma'am.
So thank you so much, Nitin.
Yeah,
I think, yeah, I saw that thing. Is it okay if I go ahead?
yeah, ma'am. Sure.
Great. So we'll start with this.
I request the others kindly to mute themselves. Thank you.
Okay. Is my screen visible and clear enough?
Yes, Ishita.
Okay, great. So I'm good to go. At the outset, I would like to thank Dr. Ajit Jankar sir and Dr. Smita Athole ma'am for having me on board, and give me the opportunity to speak on a topic which is very, very dear to my heart, which is the periodontal health care for the elderly. Today, I'll be basically be talking about periodontal changes and their systemic association. How can we prevent the progression of the disease, and how can we restore the disease? And a few take-home messages that all of us need to keep in mind while evaluating and executing any of our treatment plans. So what is aging, if I have to tell you, is something that is inevitable, and we need to look at how we can convert it into a healthy aging, and that is described as a lifelong process of optimizing opportunities for improving and preserving health and physical and social and mental wellness and independence and quality of life, and enhancing successful life course transitions. That's been published by the Health Canada, and that's, I think, by far or encompasses all the essentials required for an elderly. The picture on the left shows a top-heavy elderly chart, which is solely relying on the revenues and incomes of the dwindling younger population. What does it mean? So, and how is it relevant? It is relevant because in the near future, like by in 2050, the general percentage of the population of a 60-year-old is going to increase from 7.6 to 20.6, and the population of 80 plus elderly senior citizens are going to increase from 0.61 to 3.06. So one would think that it's okay, it's hardly a difference of points, but a very startling revelation that I would want to make is that almost all the seniors coming into that age population do have periodontitis. Unfortunately, in the gray area, they are not reported. Very few are reported. So those stats are kind of skewed, I would say. This population, like Dr. Smita and Dr. Asha and Dr. Archana ma'am have already spoken about, that they have their own limitations. They have a functional limitation, their physical limitation, they have cognitive impairment, all of that leading to difficulty in maintaining good oral hygiene, and all of that again relating to difficulty in eating. So all in all, if I have to explain that, since that life expectancy is increasing, the amount of systemic diseases that this population is going to have is also going to increase. And since the oral cavity is the mirror of the entire body, it has to be reflected and taken care of by the clinicians. So when we speak of periodontal changes, there can be two types. One, primarily, is a physiological change, which is inevitable, which would probably be clearly represented in this female patient, who is a 65-year-old patient, primarily being seen as facing or seeing a gingival recession, some amount of bone loss. And because of that recession, she's complaining of sensitivity and caries in her lower right quadrant. But when we speak of pathological changes, I would want to start with a clinical view of a young patient, where we can see some amount of gingival loss or soft tissue loss in the lower front teeth. And why I'm showing this is because this is a very clear picture where we can understand the gingival changes that we need to see in any patient, which could be in the form of a color, which is a nice pink, contour, which is scalloped, consistency is decently firm and resilient, pyramidal and triangular shaped papillae, size is normal and not enlarged, except for the lower anterior where it's looking a little inflamed and enlarged. Surface texture elsewhere it's stippled except for the lower anterior, and also position where everywhere else it's above and or at the CJ again, except for the region where in the position of 3-1. So this is a picture that we have to compare with from the previous slide of another 68-year-old male who is suffering from chronic periodontitis. We can see supraeruption and abscess formation in the upper front region. A few FPD is given in the posteriors to have a good occlusion, but because of this abscess, he's not been able to close his mouth. So I would say because of that single abscess and the inflammation in the lower anteriors, this patient has got a lot of deranged occlusion, if I could put it that way. This is my favorite picture where all the clinical features of a healthy and an unhealthy gingiva and periodontal condition are visible clear cut. When we speak of the area with the 2-1 and 2-2, we can see nice stippled gingiva margins, although are receded, but they are in a healthy state. Whereas if compared to from left side to right side, we see a chronic state of inflammation, food lodgement, gingival recession, and abfraction because of the occlusion, some erosion in the lower jaw, and food lodgement and food wedging primarily because of that upper crown into the area between the 3-5 and 3-6. So is it always that we have to address this? Sometimes the patient himself comes walking to us with these complaints, which are spaces or gaps in teeth, sometimes food lodgement and dull pain or gnawing pain in the gums, sometimes bleeding gums, is what they report, bad odor, they have brown, yellow stains or frequent tartar deposition, and they invariably, like what Dr. Asha said, that they have ulceration because of worn out teeth upbraiding against the soft tissues, and loose teeth or missing teeth, and they walk in with the complaint of having difficulty to eat food. So another classical case where we can note pathological migration. So this is a patient with hyperthyroid, a female patient. Although she could manage to keep all her teeth in her mouth, but those teeth were all periodontally compromised. As we can see, they were severely inflamed with all the clinical features that I had spoken of in my first slide. They are lost. Another case of severe periodontitis where we can see receding margin and the type of inflammation and cervical caries around the root areas. So why root areas are so sensitive? Because there is less cementum, more of dentine relatively, and xerostomia and definite gaps in between the teeth that causes the food to stay on or put on until unless they physically themselves clean it. So that's where the protocol of oral hygiene maintenance sets in, and that is where reinforcement for maintaining of oral hygiene has to be done every time the patient walks in for a recall visit or in the first visit in itself. This is a clinical case of a smoker, a young adult, if I could put it that way, somewhere around 60, 62, and now realizing that the teeth are becoming brown with some amount of recession, and the tooth are starting to look long, is what his complaint was. Another patient with severe cervical caries due to the presence of food lodgement, and he was hospitalized during the COVID times, and he has got severe he's always in the state of hyperglycemia with the HbA1c somewhere from the range of 10.5 to 14, keeps fluctuating in that range, but nevertheless his upper jaw has been doing fine, whereas the lower jaw we can see the state in. So why do we need periodontal examination? And how do we need to do it? So the clinical features that I spoke of in the first slide, where we note down the 7 or 8 clinical features on the gingiva, along with gingival recession, the amount of recession that has happened, bleeding on probing, that is usually done with a Williams probe or UNC 15 probe with a blunted probe primarily. And that is where you walk in the probe and you understand the activity or activeness of the disease state. Then you have to note down the clinical attachment level, because that is where you decide as to what protocol has to be followed and where, and obviously the radiographic examination. So when we speak of Miller's classification, that's the age-old classification system of recession that's been followed, and generally all dentists all over the world know this system. So this system primarily relies on two things. One of which is the mucogingival junction and the level of the marginal gingival, and the in relation to the amount of bone loss. So if there is any amount of bone loss, it has to go in the category of 3 and 4, and would definitely need a different line of action when the treatments have to be planned. So what is recession? So there is something known as a cement enamel junction, and from there the gingival margin level has to be calculated, and the amount of mm, maybe 2 mm, 3 mm, that's the amount of recession that is usually noted down. What is PPD? Is nothing but probing pocket depth, that's measured from the gingival margin to the base of the sulcus, and an addition of the recession as well as the PPD will give us a clinical attachment level, and that will give us the loss. Why OPG and why not RVG? If somebody asks me, I would say that RVG would give us a single amount of single set of bone loss values, if for at least minimum two teeth or three teeth, whereas an OPG would give us a generalized view of the amount of bone loss, horizontal or angular, right from one upper molar to the lower molar, as well as for the one quadrant to the other. So OPGs are of great diagnostic value. So when we speak of PPD, like I said, probing pocket depth in an ideal condition should be somewhere about 2 to 3 millimeters. That's about just how much the probe should be going in. If there is plaque deposition or food lodgement, that is going to induce some amount of inflammation in the gums, and that is going to lead the gum state to gingivitis. If that gingivitis is left untreated, that is going to progress to some amount of bone loss, and that's when your probing pocket depth is going to increase to 5 to 6 mm, and that's when we see that the where we can say that the moderate periodontitis has set in. So this aging population that we spoke of is very important, because like what Smita ma'am had mentioned, in the life expectancy increases, the amount of medical needs increases, and with the medical help that the patient is seeking, there are a number of polypharmacy, the drugs that they are taking in, and a combination or an amalgamation of all of this situation is what maybe will help the patient get periodontitis, or if a treatment of those systemic diseases are done, maybe the periodontitis can be controlled and a further progression can be reduced. So periodontitis has got definite correlation and association with neurological diseases like Alzheimer's or Parkinson's, and most of the patients walking in the OPD, they also report of some dementia. So, and when they speak of the GI problems, they have gastrointestinal diseases, which with GERD, and very, very frequently, most of those patients are reporting with reflux or acidity. Very another important parameter with what Dr. Archana ma'am spoke of was SpO2 level, that they should always be checked, and that's when we realized that the respiratory diseases are also present in those patients. So COPD is one such disease. Those periodontitis induces high level of pro-inflammatory markers in the body, and that's also that puts the body in an inflammatory state, kicking in rheumatoid arthritis. Diabetes, because periodontitis again has a pro-inflammatory state, increases hyperglycemia, again kicks in the pancreas and reduces the insulin secretion from the body, kicks in diabetes type 2. It also has a definite correlation with the chronic heart diseases, lupus erythematosus, kidney diseases, cancer and precancerous conditions, and anemia of many chronic diseases. So how can we definitely prove that an unhealthy state is definitely correlated with all of these? Is because a keystone pathogen, which is P. gingivalis, is responsible and definitely associated between all those diseases as well as the oral cavity. So if you see a starking finding in all of these diseases, is that we can see P. gingivalis as the the main criminal of all of these, in all of these. And the same microbial association has been found in the periodontitis oral cavity as well. A brief idea of how does periodontitis kicks in and what is the inflammatory association. So whenever there is a keystone pathogen, which is P. gingivalis in our case, it releases antigens and lipopolysaccharides, and that induces a state of inflammation from the body. But the body is kind of able to fight that war, and that is when a homeostatic immunity sets in and the patient is still in good health. But in the presence of modifiers, which means that there could be risk factors which are modifiable and non-modifiable. By modifiable, I would mean that anything from systemic diseases to smoking to diet to some immunity deficiencies. But by non-modifiable, I definitely mean that aging is one of those risk factors, and genetic disorders and deficiencies that are not in our capacity. So, in the presence of those risk factors, and also if the patient has got poor oral hygiene, this sets the body in a destructive inflammatory state and kicks in the inflammation to a very, very aggressive or higher extent. And that's when we understand that the periodontitis has set in, and that reverting that becomes definitely difficult. A small flowchart to show the correlation between diabetes is that when a diabetic patient has got a sixth, has more prone to periodontitis because it's known as the sixth complication. So once the diabetes has set in, it increases the hyperglycemic state, it elevates the glycation end products and the reactive oxygen species, and that leads to an exaggerated immune response from the body, again initiating periodontitis. That in turn leads to more bacterial factors and again elevates the release of inflammatory markers. So in a brief way, if I have to explain as to how oral infections are directly related to or in the bidirectional form, how oral infections can lead to other infections of the other organs, distant organs, is either they could be direct systemic invasion, or they could be a stimulation of inflammatory response leading to the damage of those organs. Dry mouth is a very, very common factor when we are talking about the senior citizens because of the prevailing systemic conditions or because of the drugs that they have been taking in. The mouth is constantly dry, so the treatment of which we will be discussing later on. Generalized chronic severe gingivitis is what we'll be seeing in the following case, where the patient has got full mouth crowns in her mouth, and we can see some state of gingival inflammation along with some debris and some extra cement which has gone into the gingival sulcus and led her to this state. Chronic periodontitis with lichen planus. Here we can see some amount of recession, definitely Miller's in Miller's classification type 4, class 4, and lichen planus that has set in all the 4 vestibules. Drug-induced gingival overgrowth or enlargements are typically looking like this with a probing depth of 5 to 6 mm. Unfortunately, it's a complicated case with no teeth in the posteriors and a deep bite. Another case where periodontal abscesses are seen with failing endo and obviously to contribute poor oral hygiene. Vertical root fractures are also compromising periodontal health, because most of the times what happens is the senior citizen age group, they get a root canal treatment done for a painful tooth, and then the crown is sometimes given or not given to them on those teeth. And even if it so happens the crown is dislodged, they are not very well aware that the crowns have to be placed back. A similar case in front of us is one such one where the premolar had lost the crown, the PFM crown over it, and the PFM the tooth kind of supra erupted, and we can see that there's a lot of periodontal inflammation around in that area. After doing one exploratory surgery, we found that the tooth had a vertical crack that had to be extracted. A very evident extraction was this with a fracture. When we speak of leukemic enlargement, a clinical picture would look like this. So what I have realized over a period of time, it's that neglect of timely repairs is what makes rebuilding very, very necessary. Desquamative gingivitis, as we can see, there's desquamation happening in the areas with the lowers and the uppers, and in this in the centric occlusion position, we can see that the lowers are hitting the upper gingiva. So that is what is causing a lot of inflammation and failing to treatment. Another case where there is a deranged occlusion, loss of video, we can see that there's food lodgement in the lower anteriors, a lot of abfraction happening in both the canine regions. There is some supraeruption happening in the posteriors, fracture of a cement. That was a restoration which was done with the 2-3, and supraeruption of 2-4 and 2-5, and slightly with 2-6. So this is all in all a very difficult case to even rehabilitate, because there is no interarch space or very less interarch space which is available. So another case of chronic severe gingivitis, where we can see there's loss of two teeth in the opposite arch. So if the uppers are present, upper anteriors are present, the lower anteriors are absent. And if the posteriors are present lower, the upper ones are absent. So such cases are difficult to treat periodontically. So another picture where we can see a periodontal health around RPD is one such one, where the patient actually went in for a rehabilitation procedure for RPD, with an RPD, but she could not maintain her oral hygiene very well. So we can see a lot of food lodgement everywhere, and also around this FPD. Around this RPD, if we can say, there is an abscess developing around the 4-7 or 4-8 region, which is now moved distally towards the 4-8 region. So this FPD, although was given to her, but it is in a very dilapidated state, and a lot of food is getting stuck from or around that FPD, and definitely very difficult for the patient to remove. So, like I mentioned previously, a healthy mouth is a gateway to a healthy body. There should be a set treatment goals, which should mean that medical clearance is very, very important. We should not start with any patient or any treatment without medical clearance. We should make sure that their blood reports and blood values and all the pre-dental workup is done. We should have a thorough diagnosis, including of all prosthetic crowns or bridges which are already present, and supraeruptions that usually people tend to miss out. We need to definitely have good behavioral management, primarily looking at reduction or elimination of pain, and thereby treatment of infection or disease, and then we can restore the function and aesthetics. And frequent recalls is something that I definitely stress upon, because more the number of recalls, more is the follow-up, more is where we can assess the patient and evaluate, and overall do a holistic oral rehabilitation for the patient. How do we prevent the progression? So in prevention, I would like to start with something with the home care. Prevention of food lodgement should be our prime motive, and we should educate the patient as to how they can themselves do it, and not come to us after every 6 months just to do scaling. I want to preach that this should be part A, where they do their homework first, and part B, where we do our dental office care and keep them in a very prevention or a preventive state. So they should avoid sticky food, and they should have more fibrous food. The toothbrushing should be done with primarily a crisscross zigzag soft bristle toothbrush. I am a firm believer that a zigzag cross bristle or an angulated toothbrush is something which will definitely work in patients who've got partial edentulous or completely dentulous patients. Brushing after breakfast and after dinner twice daily or even thrice is also fine. The use of interdental floss, water flosser, dental brushes, also depending upon the size of the mouth and the mouth opening and the size of the space which is present in the oral cavity, and mouthwashes, primarily non-alcoholic ones. So initially, when I started my practice, I knew that patients reported to us by saying that they brush only once and probably for 1 minute, and they have zero follow-ups with the dentist. But very slowly, I started realizing that a slightly younger senior population, if I could talk of somebody from the age of 40 to 60, um, they have started using the 2-2-2 rule, which means that the patient should be brushing twice daily for 2 minutes and visiting the dentist twice a year. But nowadays, the Japanese are following the 3-3-3 rule, which means that the patient should be brushing thrice a day for a minimum of 3 minutes and a time span which is less than 3 minutes after every meal. So these are a set of brushes that I personally like to advocate for. They are angulated brushes with different ranges of the tufts and the sizes of the bristles. So the first two ones are majority ones of them are from Oral-B, but the first two ones, if even if they look alike, they have a difference in the dimension or the size of the bristles and the arrangement of the bristles. They should be multi-level. They should not be in one level. That's primarily for patients who've got a full mouth FMR done and crowns and all of the teeth. But when there are spaces present interdentally, multi-level kind of a brush is what is going to help them. So the third brush is where the pressure sensitive feature of the brush helps to prevent damage to the gums along with cleaning the teeth. The fourth one has got rubber tufts or rubber bristles, which stimulate the gingiva when the patient is brushing. The last two ones are specially meant for patients who've got bleeding gums and just after implant therapy or a periodontal flap surgery, they should be using these brushes, all obviously in a very gentle manner away from the gums towards the teeth, so that this oral hygiene around those teeth and the newly grafted or surgical area can be maintained. So this is this is only possible when the patients have a good dexterity. When the patients lack dexterity, then the only action that we can tell them is scrubbing action. So by scrubbing action and gentle sweeping, they'll be able to maintain their oral hygiene despite of the fact that whatever brush they're using, at least this technique will serve them well. Patients who do not have who have just been treated with a flap, this soft bristle brush will definitely help them and remove plaque and debris from the interdental areas. An electric brush will definitely help patients who have no dexterity and need to hold the brush, where the brush is going to do the maximum function and remove plaque and debris around the area and prevent them from calcifying into tartar. These are a variety of toothpastes that I advocate, primarily because the fluoride content in all of these is more, and also they have a triclosan, and some of them have got some antibacterial contents that prevents food lodgement. No, it kind of prevents the food from decaying and causing tartar and caries in those areas. When we speak of sensitivity, Thermosil is one of the easily available ones, and it prevents sensitivity and those pain for the patient. So when we are prescribing mouthwashes or the patient asks us, is it okay to use a mouthwash? I tell them specifically and I ask them specifically which mouthwash are they talking about and which mouthwash are they really going to buy. So I would say safe option is to write it down for them. But most of them are come and tell me that Listerine they've been using and they've been doing fine. But as a matter of fact, Listerine is one of them which has an alcoholic content, and all the other ones on the left side, they have no alcohol. So whenever you are prescribing something, maybe use it once on yourself, and also read the contents. So just so that you know that you have to prescribe alcoholic or non-alcoholic ones. It's okay if you prescribe an alcoholic one to a younger patient, or anywhere who does not have so many systemic problems. But definitely patients who have got systemic problem, all of these alcoholic mouthwashes are going to cause some amount of xerostomia and burning sensation. Also flossing. So I'm a strong believer of flosser as well. I tell all my patients of implants, of crowns, of failing perio, that they have to floss. So even if I have to preach that 10 times, I'm sure that they will listen to at least the 5 times that I've told them, and go about it. So flossing, there are several techniques which are available on YouTube. You should see that what suits you, and you should tell the patient the same. If they feel that flossing is something that is easy for them, then it's fine. Otherwise, there are faucets which are available that they should use in the interdental areas to keep it clean. Also, water flosser is one such an advanced gadget that helps remove plaque and food debris around the interdental areas. So plaque as such is the only way we can remove a biofilm, unfortunately, is by scaling and root planing. But the flossing and brushing can at least help remove the food debris which is sitting around in the teeth. Also, interdental brushes, there are several sizes available in the market, and a few companies give packaging like in assorted sizes, where we can use the right size for the right space. So it should not so happen that we are using a wide interdental toothbrush for an area which is very, very narrow. We are going to injure the interdental papilla, and it's not going to solve any purpose. One more practice that I have started in my one more habit that I've started in my practice is the use of disclosing agents when the patients walk in for a recall appointment. So I tell them that I'm going to evaluate you on the amount of staining that happens around in your mouth, and then we are going to decide as to how many sittings you're going to need more in order to become, or in order for you to maintain your own oral hygiene well. So this is a case of denture stomatitis, which is healing. And how do you care for dentures? With the help of toothbrushes and denture cleansing tablets. There is something known as obviously the candid solutions for used onto the areas where the fungal infection has set in, and it kind of treats it almost completely. But as a matter of advice, I would always tell you that keep calling such patients, because the fact that the denture has not been kept clean is the fact that the fungal infection has set in. So when we speak of oral rehabilitation, we are talking about dental caries, restoration of dental caries, periodontal diseases, elimination of pain, treatment of precancerous lesions, and denture stomatitis or burning mouth syndromes. So a non-surgical therapy, I would say that by scaling and root planing and an adjunct role with antibiotics definitely solves the purpose. So this is a case where the patient was a chronic smoker, and we were able to do multiple sessions of scaling and replaning, and to achieve in a state where further reference to the prosthodontist could help him achieve some amount of occlusion. This is a patient with post-radiation care, like Dr. Asha had spoken about. Here we can see that the patient has got severe amount of plaque and debris along the marginal gingiva and onto the teeth, which have got caries. So after we do multiple sessions of scaling and root planing, we realize that they have definitely have got radiation caries and need further referral to an endodontist and a prosthodontist for rehabilitation. Lichen planus is one such problem that most of the senior citizens are facing. And treatment of one such was, we were successful in doing that by multiple sessions of scaling. I was almost doing an oral prophylactic session for her for after every week, so almost all Saturdays. And after 1.5 months, I could see this result, along with some um, topical triamcinolone agents that we prescribe. But primarily because she was able to maintain her oral hygiene well, and despite the fact that there is a few interdental areas with food debris and food lodgement, still the lichen planus area is reducing. Treatment of leukemic enlargement is usually done not without you're not without the main concerned oncologist in hand. So you have to let the oncologist know that this patient would need scaling and root planing. And then, since the platelet counts are anyway low, they infuse some platelets and increase the PCVs, and then we proceed with the scaling. So obviously this patient also needed multiple sessions of scaling and multiple sessions of blood transfusions before we could actually see this result after 2.5 months.
Dr. Ishita,
Yes,
just let me lightly remind you about the
yes,
time.
yes,
Yeah.
yes. So dental office care definitely would mean that we need to perform oral prophylaxis, do subgingival curettage, as well as do surgical periodontal therapy. So why are we stressing upon regeneration or prevention of disease? Is because when the patients are in a state of gingivitis, we can treat them by just doing oral prophylaxis. But when the periodontitis has set in, that's when these two modalities work. Primarily one, which is repair. So repair will only happen only after deep scaling or just curetaging the granulation tissue. But when we speak of regeneration, we have to surgically go into the area, clean the granulation tissue from the bony defect, put a membrane, graft the area, and then close the site for healing. This regeneration, although it takes me just 5 minutes to explain it to you, but would definitely happen over 3 to 4 months time. So another case where surgical flap therapy was done without any regeneration, and restorative dentistry and a few splinting, because the probing depth was somewhere around 4 to 5 mm, and these 3-4 teeth were mobile. We can see class 5 caries. So we excavated the caries, we placed MTA in that area, we sutured it back, and splinted the teeth together. So surgical regeneration therapy is done for endoperioral lesions like these, where there's a lot of recession anyway present. There is a lot of food lodgement which is happening with 2-7 and 2-8 area, and big abscesses around those areas. So endodontic treatment was done, flap was open, the surgical debridement was done. After evaluating the amount of bone loss, which is the furcation involvement here, we grafted the area, we put a membrane, and we sutured it back and find to achieve margins like these. So after achieving this margin, we put splinted crowns on these so that the 6 and the 7 could both be supported. If you can see slight gap in this region, it's because we want the gums to ultimately grow back in this area, because this was attempted immediately after 2 weeks or some time, because the splinting had to be done. So all of this, although the literature says that you have to wait till the gums heal and then you have to decide on the gum margin as to where to the crowns have to be placed, but this area is something that I have experimented, and I've realized that the gums eventually grow back to the level and they stay stagnant there. Another case where an endoperial lesion was treated for furcation defect in the lower molar, and that's the amount of regeneration we achieve after 6 months or 8 months, and follow-ups also it's remained constant. So surgical regeneration for TFO. So TFO is something where trauma is been happening in the interdental area due to the presence of high points in the crown or deranged occlusion, and you have a lot of bone loss in that area. So you graft the area, put a membrane, suture, and relieve the crowns from contact so that there is good regeneration happening in that area. In a drug-induced therapy, we initially started, we couldn't get a medical clearance from the doctor because he had to change the medicine. He was on nifedipine. So we did multiple rounds of scalings for almost 2 to 3 months. And we realized that it's not solving the purpose. So finally, we got a medical clearance from the doctor. And we went ahead and we did a flap. And this is what the amount of this is the amount of healing that we noted after 2 to 3 months time. And the patient has been good on follow-ups. I'll just quickly rush through the peri-implant health that is essential. Uh, as we can see here, the crowns are, you don't even realize that the implants are there, sitting right there, until unless I show them to you, because the peri-implant health has been maintained nicely. Implants like these and cases like these come to us for regeneration, which obviously all of us understand that that's technically not possible. So much of bone loss has happened because at the time of placement of those implants, the soft tissue and hard tissue profile was not assessed. So if you don't assess that, you're practically placing implants in basal bone and there is no soft tissue coverage. So it's all oral mucosa and there's no mucogingival junction that is there. It's all oral mucosa everywhere. So whenever the patient has movement, the lips are moving while talking, while eating, there's a lot of food which is getting stuck. Although in the case here, we can see that there is some amount of clearance that the patient could maintain. It's all plaque and debris, but here there's a lot of calculus that has started to set in. So mucogingival junction, like I was talking about, is something that is very, very important. Although we can see a good implant, peri-implant tissue here, but here, even if we feel that the mucogingival junction is almost lost, but on the in the picture on the left, we can see that there is still 2 to 3 mm slightly present. I'm sorry, 1 to 2 mm. So in this case, we can see that there is a 2 to 3 mm of a mucogingival junction present. We temporize the case because we want to make sure that it's the food lodgement is not happening under the crown. And then we proceed with the finalization. Another case where we deepen the vestibule so that that part of the soft tissue, we can suture it onto the implant head and achieve some amount of attached gingiva. So again here, the attached gingiva was missing on the last most implant, distal most implant. A lot of plaque accumulation. So we open up, we curettage, we place bone grafts, we put membranes, and we suture it back. And here in this case, we tied it up with the prosthesis as well, so that it kind of stays in that state. And that's the amount of healing that happens. So in this, if we can compare in the first picture and the second picture, the thickness of the mucosa has increased. Even though the threads are visible, but there is a lot of tissue which is present, which is going to do the resiliency, which is going to act as a bouncing agent for the food debris that comes in. So this picture I specifically kept because we can see that there is no cleansing that the patient can do on the left side because there's no space for the brush to go in. So this is the deformity that this zygomatic implant supported overdenture has caused, and absolutely no place for the patient to clean the teeth. Whereas a denture like this would definitely keep this area clean, but I have no idea why he's not been able to keep this area clean. So this is something that we have to constantly keep reinforcing. So take-home message would be that preservation of vital tissues. Periodontal pocket elimination therapy would definitely result in recession, but we have extracorneal splints or PFM crowns that could act as splints and prevent food lodgement in those areas. Regeneration of periodontal flap therapy versus extraction, I would definitely advocate that extraction of grade 3 teeth should be done as soon as possible because they are hopeless teeth, whereas least extraction and splinting and attempting regeneration in cases of 1 or 2 teeth is good. In case of good bone around the root stumps, we can consider root submergence whenever possible. And especially in implant therapy, now it's gaining popularity, root submergence as well as partial extraction techniques. Obviously, a very important factor in that the tooth should be periodontally sound and there should be no periodontal infection around those teeth when you are doing partial extraction of one of the segments. And lastly, I always say recall. So I always tell the patients to walk in free, just call up and just come in just for a follow-up around your birthdays, around anniversaries, around festivities. So just come in for a follow-up. So take home message, like I said, good oral hygiene, preserving and protecting the natural, restoring and rehabilitating for a very, very good quality of life, even at that age, and frequent recalls. So aging definitely isn't about how many years you've passed and how much life you've embraced. That's my team that I work with. Thank you so much.
Thank you so much, ma'am, for a wonderful lecture. Then I request Dr. Om sir to give a vote of appreciation to Dr. Ishita ma'am.
Hello. First of all, thank you very much for accepting our invitation for this lecture. The lecture was wonderful, and the cases on the display were good. Actually, there are no questions from the participants. I want to ask one question only, and is if you are attached to an hospital, so what is your experience periodontal care for the hospitalized patients? Hello, Dr. Ishita.
Hello. Yes, sir. My experience for the hospitalized patients.
Yeah.
So very often the ones who are admitted in the wards, we have them in the department for a scaling session. So at least whenever we are doing oral profile access, we come across many incidental areas or the areas on the proximal surface of the proximal surfaces which have got class 2 caries. So sometimes the caries go unnoticed during evaluation, but whenever we are doing scaling, we come across those. So also we definitely need medical clearance. So first we have to talk to the treating surgeon or the physician or under whoever the patient is admitted, and check their blood reports and the medicines that they're on, and then come back to what has to be done and how much can we do for the patient.
Okay, thank you very much.
Thank you, sir.
Over to the organizing team now. Thank you.
I request Dr. Om sir to give the certificate of appreciation to Ishita ma'am.
The certificate of appreciation will be on your screen now. Just wait for a minute. Yeah, this is the certificate of appreciation. Kindly accept the certificate. Thank you very much.
Thank you, sir.
Thank you. Over to Dr. Shivani. The next section is by Dr. Paresh Gandhi. The moderator for this session is Dr. Shashi Patil sir. Dr. Paresh Gandhi sir has done his BDS and MDS from Mumbai University with gold medals at both the levels. He is a consultant prosthodontist and implantologist practicing from the last 25 years. He has completed his master's in dental lasers from the University of Vienna, Austria in the year 2009. He is passionate in prosthodontic planning in implantology with special emphasis on full mouth rehabilitation and lasers in practice. He has delivered several national and international keynote addresses as guest speaker. He actively conducts workshops on FPD and implants. His recent passion has been in soft skill training for dentists, which has immensely helped clinicians in their private practice. He has been the past president of Rotary Club and was a director for several years. He's the past president of member of reviewer committee of JIPS. He's also a consultant prosthodontist and an implantologist at Pune Hospital, Pune, and is running his private practice since last 2 decades. So we are very glad to invite you, sir. Now you can start the presentation.
Thank you so much for those kind words. Kindly excuse me, my internet connection is slightly unstable. I hope you are able to hear me.
Yes, Paresh. In case there is any difficulty, I will advise you can, after starting, you can put the video off so that you get more bandwidth. But right now you're okay.
Yeah, just give me a minute.
Sure.
Okay. So that was about me, which was already told to you. And just reconfirming, is it visible and audible?
Yes, Paresh, please go ahead.
All right. So good afternoon, everybody. At the outset, let me thank the organizing team led very efficiently by Dr. Ajit Jankar for organizing this excellent symposium and giving us an opportunity to be a part of this. So friends, so far this was all brought to you by Sai. So with the blessings of Sai and all that has been said, heard and seen, I think very little is left for me to, it's kind of going to be a wind up. So you would be wondering what Sai is all about. So S is our leader, the champion of geriatrics throughout the country is none other than Dr. Smita. A would be for Dr. Archana. Second A is for Dr. Asha and R is for Ishita. So if you would be wondering what Paresh is going to be, Sai has already wonderfully taken up the champion cause of geriatrics to you. So let me try to be very brief and drive home the points which I feel are supposed to be taken up by me, but it's kind of going to be a slightly overlapping. So we all have seen that the common problems of geriatric patients, we all know them. And multiple problems are there, which we have seen by all the four speakers before me. So we will go ahead. So you would be wondering what all this is about. So geriatric patients generally could have so many problems which are not seen or felt, but you could, by mere simple signs and lot of telltale signs, we could come to know their issues. So it is our duty to try to understand them, hear them out patiently, and be compassionate towards them. As Dr. Smita rightly said, aging assumptions. You will never try to jump to any assumptions regarding any patient, forget geriatric patients also. So complete and partial edentulosum, is it a boon or bane, especially for prosthodontists? If I ask this question to all prosthodontists, there would be mixed opinions and reviews about how will you tackle complete edentulism, partial edentulism, more so in specially debilitated senior citizens age group of our patients. Is it easy or it is going to be difficult is what we will try to see. We all know that ill-fitting dentures is the biggest curse we could be getting from our patients, simply because there could be some natural limitations from the patient side, but it could also be a professional fail from our side, not being able to deliver the best complete denture. So let's all be very honest with ourselves and be extremely transparent to ourselves and ask ourselves this question: how many fully satisfied complete dentures we have given to our patients so far? And I'm sure there could be a mixed answer, a mixed view. It cannot be a 100% score of a century of all the successful dentures. There are always going to be some lacunae in the deliveries which we are giving to our patients, and more so in a completely edentulous state where our impression making and all the subsequent steps are put to maximum test, and then we can rest assure our patient that they are going to be satisfied. So there could be a variety of symptoms and causes have to be identified and tackled. In spite of all this, we must bear in mind that atrophy of the ridges is the biggest curse a geriatric patient could have. And this could be leading to a very unfavorable inclination of the intercrestal line. And because of which our teeth arrangement, which otherwise in a dented patient could be classified as class 1 very easily, may not be so in a severely completely edentulous patient. So the posterior teeth eventually could be set up in a crossbite occlusion, and this evaluation and interpretation lies with us. So whenever you are planning a plan for your geriatric patients, now I will shift gears and come to implant treatment options for geriatrics. We have to be very, very clear in what type of a treatment plan we would like to give. Could it be an ideal treatment plan, which could be an academic, where it could be a treatment which is on demand, plus oral examination complaints of the patients are going to be fulfilled, and if there are any medical reasons for the dental treatment, or it could be a clinical treatment plan, which is a reasonable treatment plan, keeping in mind the general health and functions of the patients, physical and mental backup of the patient, whether a patient is incapacitated in any way, ratio of cost to benefit, and autonomous problem. So first option could be an ideal treatment plan. Second option could be a reasonable. Third could be a practical treatment plan, which is possible. This could be a subjective treatment demand ratio, wishes of the family, financial aspects driving the treatment considerations, and dental preliminary treatment or invasive diagnostic. And last could be modified treatment plan. So we have to be very, very reasonable in trying to identify which of this treatment plan. Not always our ideal treatment plan could be perfectly suited for all and every geriatric patient. So what are the options we have for completely or partially edentulous patients? First is our gold standard, giving them removable prosthetic solutions by way of a full denture. Second could be a simple 2 implant supported overdenture. Third could be 4 or 6 implant supported hybrid overdentures. And last options could be all on 6 or all on 8 completely full arch fixed rehabilitation. But we are always going to be tempted to suggest, and we should suggest, implant-based options to our geriatric patients without considering that they would not be happy with them, they could not take the treatment up. Our duty would be morally to try and suggest to them implant-based solutions if it is going to be within the purview of our treatment scope. So this is a case of mine, 15-year-old case. Patient is now 60. So under this treatment while she was 45 years of age, and we had options of giving her 4 implants, which she has maintained excellently. So 15 years down the line, and today also she's quite happy with this. And because of this, I would still strongly urge you to consider implant overdenture solutions to our geriatric patients. So it is a tightrope walk between understanding the problem and the complaint. Also keeping in mind that every patient or person has a right to better quality of life. So are our geriatric patients. Life expectancy has gone up. So better life expectancy, better fruitful years, more justification going towards implant-based solutions for geriatrics. They have to be able to enjoy all the everyday things of life. Definitely, they cannot be deprived of all the basic pleasures of life, which includes eating. And of course, they have to be able to avoid social isolation and anxiety, because we all are human beings and we are social animals. So we would like to be a part of the society. So considerations for implant treatments would be, few of these factors have been already considered by the previous speakers. So let's see, comorbidities, very, very important. Medical clearance is mandatory. Understand the medical history in detail. If you are not in a position to take a call on it, please consult the physician and take their consent. Psychological issues, very, very important, sometimes overlooked in an attempt to quickly go ahead and do the treatment. But understand the psychology of the patients, whether they are in a position to accept what you're trying to give them. Nutritional deficiency, very, very nicely explained previously. Identify them and put them on some pre-medications before you commence any kind of treatment. These patients are more prone to infections because of general frailty and the loss of immunity. So that could be a problem you have to keep in mind. More prone to small injuries, and injuries could manifest in a bigger way during routine procedures. Nerves could be damaged, sinus issues, and slower healing rates are a few of the things you must consider. And most importantly, bone deficiency. So looking at a senior citizen, healthy patient, looking at the patient intraorally, if you find the ridges are poorly formed, they're looking well formed, but they could be bone deficiencies. So mandatory checks for X-rays and bone densities becomes absolutely mandatory before you commit to the patient any implant-based solution. Our aim basically should be to reduce the morbidities, and remember that comorbidities are common. Reduce morbidities is post-treatment, during treatment, and after treatment. It should not be that we're adding and piling up more maintenance to our patients by suggesting treatments which are going to be beyond their capacity to handle. So bone deficiency is the biggest bane for all of us. We want to rehabilitate and restore the jaws of the patient, but many a time situations are that patients are affording, but the bone is deficient. So we have to try and consider what best options. The figure on your right shows advanced implantologies by going for zygomatic implants, pterygoid implants. So unless and until you are efficient to handle these situations and the patient is medically and surgically fit, please decide whether you want to go for these procedures or suggest some simpler solutions to our patient. But yet we would still like to suggest implant as an option, because we all want to aim to increase the resiliency of the patient. And for that, these are the standard guidelines which I'm trying to present. First is go for standard implant placements. Please try and avoid any kind of bone augmentation unless it is 100% mandatory and patient is medically and surgically fit to take it up. Use of surgical guides to reduce post-op morbidity. Very, very important. This almost minimizes the post-op morbidity and patients can cope up with our procedures very well. No harm in using narrower implants, but broader implants. Go flapless if possible, and use of modern imaging and minimally invasive procedures and single stage procedures to reduce the number of appointments. Also important will be to consider and forecast what type of prosthetic outcomes you are likely to give to your patient. The key points would be, it has to be a simple prosthetic design, easy to maintain. That should be our main priority. So keep the design simple and minimalistic and understand the cognitive abilities of your patient. Surgical guides. Now we are in the era of digital dentistry. We have all the advanced imaging technologies to our disposal. Kindly make use of them and use radiographic guides, surgical guides. Never mind if it is a single tooth implant, two implant situation, a segment, quadrant, or an arch. Try and go for surgical guides because these are not only pre-planned, but they will avoid and minimize any exposures during the surgical procedure. So use CBCT as a mandatory gold standard for planning all our cases. You could do virtual placement for accuracy of your implant so that you don't have a lot of things to manage during the second stage or third stage. So go full-fledged, begin with the end in mind, and then go backward and plan your implantation for your patients. We definitely don't want the population of implants in the jaws of the patient because this is not at all warranted. We have to keep our designs which are going to be easy to carry out, execute, and of course to maintain. So use of short implants will take care of the vital anatomic structures around sinuses, mandibular canals, and there is no harm going for shorter implants. But at the same time, try to go for broader implant because that could take care of the biomechanics of loading of implantology. Please avoid this, as I've already said. There is no need to suggest bone grafting and augmentation for all the patients unless it is absolutely a must. All-on-4 could be a good solution because this gives a fixed solution, yet it is within the foramens and avoiding all the vital landmarks. And this could now be done in an era where you could pre-plan the procedure well in advance, place the implants, and also load it in the same appointment. So all-on-4 is a good solution. So basically, it is a metal reinforced acrylic hybrid. Advantages: it's a quicker procedure, less number of appointments will be required, no grafting, relatively easy if you go the graftless, and you can try to go for a guided procedure, easy on maintenance, and generally is more economical than going for full arch fixed implant rehabilitations. Going flapless, this is the key. Unless and until you are well experienced to handle routine cases, please don't try to venture into this. But yes, going flapless will almost maintain your periosteum intact. The healing post-implantation is quicker. Patients are also very comfortable right from day one of the procedure, and their compliances for further appointments would be also far more cooperative. You could also plan to do 2 stages together, that is placement of your implant and gingival former all together. So the 2 stages going into one appointment with a single anesthesia, no suturing, no incision, no almost less bleeding. So this takes care of the post-op morbidities. Implant care, as Dr. Ishita rightly said, is mandatory and very, very important. And I like the way she said that recall your appointments during your birthdays, anniversaries, or anything. And that would be a best reminder to ourselves to keep ourselves for a regular follow-up protocol. So what would be the best way forward? Could be attachment retained prosthesis, because they will restore the functionality, they will restore the aesthetics of the patient, phonetics of the patient. Hygiene requirements and maintenance is quite easy. And simple overdenture solutions is the first step you should all embark on in treating our geriatric patients. Simple B&D location, 2 implants with any kind of attachment depending on the prosthetic space available is your gold standard to try and uplift the comfort level of these patients in day-to-day life. So why should we consider overdenture as an option? Because many a times geriatric patients will have an unfavorable jaw relation. So merely because the bone is available, if you insist on giving a fixed restoration, your labial flange is going to be missing in a fixed solution and the lip support is going to be compromised. And aesthetically, this could not be a best way forward. So whenever you feel the jaw relation is unfavorable, friends, please do consider overdenture, because the flange is the only way you could give an adequate support required for your lips. So rather than leaving the patients handling themselves and getting crippled with removable dentures, don't you think an option of suggesting an overdenture could be the easy way out of a situation where you could suggest implants also, give them a fixed solution also, yet patient can remove it, maintain it easily, and carry out their daily basic requirements of mastication, phonetics, and socializing with much ease. And it's a very, very predictable outcome. And of course, economically, this could be the best way we could handle that situation as well. So this was a case which we did where the patient was not in a position to go for any kind of bone augmentation manipulation. So we have decided to go for 4 implants placed. But the angulation of the premaxilla mandated that we had to use the RINE 83 with ball attachment in order to get the path of placement and removal for the overdenture in a parallel manner. So that takes care. So this is a metal reinforced cast partial denture with RINE 83 attachments on 4 implants, trying to manage the angulation of the implants, which was dictated by the angulation of bone. So again, an overdenture upper and lower. Similar case for a maxillary 2 implant situation. You can identify very easily that the premaxilla is projecting labially outward. Implants naturally had to go in the direction of the bone, and then we could manage them and get them parallel with the ball attachment coming on the crest, and that took care of it. The subperiosteal implants are also coming back with 3D designing and printing. So they are lesser invasive, but the framework requirement is quite huge and broad. So unless the patient is really in a dire need of them, consider them. Overdenture bars, the gold standard few years back, still could be considered if you have adequate interocclusal space. And they provide you good retention and stability. The concentration of the implants is distributed because they are splinted together. They prevent the vertical dislodgement. The only drawback is hygiene maintenance sometimes could be cumbersome in the area beneath your bars, and technically they are quite demanding. So this is a case of 4 implants with your abutments and a bar which is connecting. And these were the retaining caps, horseshoe-shaped denture, palate is left open, patients feel psychologically better, and an overdenture given to this patient, riding on the 4 implants. So whenever you are going to be deciding and suggesting to a patient overdenture implant solution, please keep in mind certain criteria. You have to consider the height of the attachment with the denture cap. Then what are the different heights of the abutments of your implant abutments? What levels of retention are you wanting to suggest to your patients? Whether you need any correction of inter-implant non-parallelism, patient's ability to retrieve the denture and put it back, and which is going to be your material of choice. So this could be a separate talk by itself, which are the factors considered to suggest an implant overdenture situation with which type of attachment. So I feel so that dental implants definitely will make a difference because they will change the lives of your patient for better, gives them improved physical health, and most importantly, a confidence of living life to its fullest. So friends, this was brought to you by Sai, as I told you. But remember, the champion of geriatrics is Smita Athawale, and नावामध्ये Athawale असल्यामुळे she always remembers geriatrics. Archana Dusia, madam, the word arch is already there. She's an oral surgeon who establishes the arch form so wonderfully for all our patients. We have Asha. The meaning Asha is creates hope for all the geriatric patients. And Ishita Paralikar, who is a periodontist, maintains the perio and the rishta with the periodontium of the natural teeth or of the teeth which are rendered hopeless, and by highlighting the importance of maintenance. And of course, last would be Paresh, which has a Resh in his name, who draws a line between implants or no implants for all our geriatric patients. So it's not a panacea. It's not a will that every missing tooth will be replaced by an implant. So please draw a line for yourself very well and understand when you will say yes and when you will say no to our patients who want implant rehabilitations. So that was all from my end. And thank you very much for the audience for a patient listening, and hope we have been able to drive home the point of our mission of bringing geriatric dentistry into forefront and into the limelight. Thank you so much once again, the organizing team. So that was all from my end, and thank you very much for the audience for the patient listening, and hope we have been able to drive
Thank you, sir. As rightly said by Dr. Paresh, sir, and the option for the treatment option for genetic patients should be as simple as possible. And like sir rightly said, go for over danger rather than the modern technologies like Zagno implant or or rather than going for hi-fi technologies, go as simple as possible. So, and thank you, sir, for enlightening us with your topic and giving your valuable time for us. And rightly said by you, and thus whole credit goes to site team and for yourself, Doctor Sir. And thank you, sir.
Thank you so much.
And
I request Dr. Shashi sir to give certificate of appreciation to Dr. Paresh Gandhi sir.
Hi, Dr. Ajit.
Hi, Paresh.
So please accept this e-certificate as a token of appreciation.
Thank you so much. I think I was blessed by Sai today and the connection stayed stable and it is still going strong. So if you want, I can extend my talk also.
It was a very wonderful session today we are having. So I request Dr. Ajit Jankar sir to conclude our today's webinar and give the vote of thanks.
Ajit, you are on silent. Just unmute yourself.
Hello, madam.
Yeah.
So
Hi,
it's a
Ajit.
great pleasure after a long time. Actually, the journey started from last IPS conference in Pune. I had a verbal talk with madam, and with a short notice, madam has accepted invitation to arrange one wonderful workshop, geriatric dentistry workshop in our college. It's a great pleasure, madam, to attend and listening all the eminent speakers. It's a very enlightening talk for the for student point of view because it's a very good topic for and is up as a need for today's society for dentistry. And I think all not only prosthodontic, is a team efforts of endodontist, prosthodontist, and oral surgeon, and all periodontists that come together because this is a very noble and social cause for these geriatric patients. We need to take in considerations, and we had to set some different way of planning for treatment planning for these patients. In the end, I like to thanks my management, Dr. H.T. Karat sir, because without their support guidance, this may not be possible to conduct this wonderful workshop. My vice principal, Dr. Suresh Kagnes sir, Dr. Yatish Joshi sir, and in the end, I like to thanks all the speakers because the madam has taken last 4-5 days. She has taken lots of efforts to get things done as per schedules and everything. Thank you so much, ma'am. I think we are knowing each other for a long time, and thanks for guidance for each and every time for your motivation, your guidance for things. And definitely in future also we are planning some one workshop in our college in most probably next year. And thank you so much. And in the end, I like to thank my all postgraduate students, my staff, departmental staff, because their support I may not be possible to conduct this workshop. Thank you so much.
Pleasure
Thank
was
you so
ours,
much.
Dr. Ajit. It was wonderful. And first of all, when it is success, it's the team. I'm very proud of my team. And, I don't want to thank them because, there are some people whom you can take for granted. So Asha, Archana, Ishita, and my star speaker, Paresh,
Paresh.
always I'm so comfortable when they are with me. And when we are with each other, we always have that feeling that the program is going to be a success, whether there is bandwidth or no bandwidth. What say, Paresh? Right? Yeah.
Absolutely. Smita is our Rohit Sharma leading our Indian team so successfully. And we are always happy to be under her tutelage because we know that the opening batsman is going to take care of everything we're going to follow. So usually she leads and I'm the tail ender coming at the end. And we have all the middle batsmen also strong enough to, leave very little responsibility for me towards the end. Thank you so much, always.
Yeah.
Thank you so much, Paresh sir.
Paresh sir, you are the good finisher.
Yeah, that's what I said. Paresh is our star speaker. He brings life back to the program. That's why he's at the end, perhaps, because, he shakes up everyone and brings everybody back to the stream.
It's my attempt and a learning curve for Miss Smita, as I always tell you every time, that every time and every stage and every podium is a new learning experience.
True.
But
So
today
true.
I got severe, so jittery because the connection at Bajirao Road, I'm speaking from a clinic. So it was giving me absolutely tremors. It might just not happen. But God's grace, it worked.
Yeah, I know. It worked well. Thank you
Bhushan,
so
thank
much.
you for being there.
Thank you.
Yeah. Thank you, sir. Thank you, sir. Once again.
Yes. Okay.
Thank you. Bye-bye.
Thank
Thank you, Dr.
Bye.
Bhushan. Thank you, Dr.
Thank
Ajit,
you.
once again. And
A
thank
good day
you,
and happy
everyone.
Diwali. Happy Diwali to all of you.
Yeah, absolutely. Happy Diwali to everyone.
Happy
Thank
Diwali.
you.
Yeah. Thank you, ma'am.